All right. Well, good evening, everybody, and happy New Year. And thank you for joining us for this session of Therapy Ed's online office hours. If you would, I had a little funny setup issue earlier, but can y'all just give me a thumbs up or just let me know that you can hear me? Just want to make sure that there's not any issues or anything. So awesome. Thank you, Haley. Thank you, Guadalupe. So appreciate it. Um, yeah, so just uh, got a few folks that are still signing in, and while they're doing that, let me just go over a couple of housekeeping announcements. And the first is just please remember to mute your microphones when you enter the room, or if you got them on right now, that'll just help in terms of the recording everything. We are recording this session and it will be posted to Therapy Ed's PT YouTube channel. So if you need to go back and take a look at anything, then that's going to be available to you. And let me quickly introduce myself. And my name is Tom Sutlive. I'm on faculty in the Army, Baylor University. I'm sorry, let's see. Somebody's saying can somebody can't hear me, but everybody, y'all are good. It looks like everybody else. So Ria, I'm not sure if that's maybe something with your connection or if you're listening through, make sure that you're listening through the app as opposed to just the browser, but sometimes that can cause a little bit of an issue as well. It looks like everybody else is able to hear me. And now I just realized now that I've said all that, let me go ahead and type that to you because you wouldn't have heard my you wouldn't have heard my comments anyhow. So yeah, hold on just a minute, folks. Okay, sorry about that. Yeah, so my name is Tom Sutliff. I'm on faculty in the Army Baylor University program in San Antonio, Texas. You can see a little bit of my background on the slide there. And I've been an instructor with Therapy Ed since 2011. And I'm also the co-editor of the Therapy Ed Review and Study Guide. Maybe some of y'all, or I'm assuming a number of you are using that as a resource to help you prepare for the examination. I love what I do. I love working with students like yourselves, and looking forward to spending the next hour or so with y'all. Most importantly, this is an exciting time for you, and I'm assuming that a good chunk of the audience tonight is taking the examination coming up in January. But if you would just go ahead and use the chat box and light it up and let me know when you're taking the NPTE. Awesome. So a couple of you are going to be taking, or at least a few of you are going to be taking the examination in January, April. All right, Harry, I see you. Yep. Okay. All right. So looks like most of you are going to be taking the examination coming up here either this month or the next iteration of the exam in April of 2024. So good deal. Well, what we're going to do tonight is cover it. It's a fairly focused, a fairly specific, a fairly niche topic, if you will, and that's going to be pediatric musculoskeletal disorders. But I also think that it's an important one, and it's important from the standpoint of we want to remember that as as PTs, but then more importantly for you all as examination candidates, taking the NPTE coming up here real soon, you want to remember that you're going to be tested on your content knowledge and the management of patients across the lifespan. So we're going to take a look at several questions tonight that cover a number of pediatric musculoskeletal disorders. We're going to review some of the information, some of the content that is related to them. And yeah, we're gonna cover these disorders in the context of answering. And what I have prepared for you is 6 simulated national licensure examination questions. All right, so let's take a quick look. And I know y'all, especially with everybody taking the exam coming up here real soon, that you're familiar with the content outline. You know, the new version of the content outline that is effective this month, and it's effective for the examination starting at the end of January. But the musculoskeletal system does indeed cover the largest slice of the exam. So that ends up being, we take a look at this next slide, that ends up being about 27% of the entire examination. So we refer to the musculoskeletal systems, the neuromuscular, and the cardiovascular and pulmonary, or cardiopulmonary, as the big 3. That's 65% of the examination. That's essentially 2/3 out of the entire examination is going to be based on content from those 3 systems. More specifically, a little bit more than 1 out of every 4 questions is going to be based on the musculoskeletal system. And it's real clear in the content outline, as I mentioned a moment ago, that we want to make sure that we're prepared for questions across the lifespan. So patients that deal with a pediatric patient, patients that deal with the geriatric patient, and everybody in between. And so to be clear, the pediatrics is not a topic on the examination. It's not a category. It's not a system that you're actually going to be graded on. But there are going to be questions on pediatric or physical therapy management of a patient with pediatric disorders across the lifespan and across multiple systems too. And I won't take a whole lot of time to go through here, but this I've copy and pasted from the fsbpt.org website in the description of what we see for the musculoskeletal system. First on this slide with examination, but take a look at what is highlighted in yellow, right? Those words across the lifespan. Same thing for evaluation, differential diagnosis, and prognosis questions across the lifespan. And then the same thing for interventions as well. And on this slide, so, what are the questions? What are some potential topics or disorders that NPTE questions might be based on in terms of pediatrics and the musculoskeletal system? I've got them listed here. I'm not going to read all of them off to you. We've got the first couple of topics there, the arthrogryposis and osteogenesis imperfecta, some congenital disorders. Really the same thing with Duchenne's, and you may look at Duchenne's and think, well, isn't that really a neuromuscular? Wouldn't that fit better in the neuromuscular system or that category? And I think you could make that argument. I think that that's a fair argument, but the disorder is a disease where there's a defect in the gene that produces the protein dystrophin. And what we're thinking about is how it affects that whole contractile apparatus, right? The dystrophin is one of those structural proteins or anchor proteins within that whole contractile structure. And so I think it's fair to consider it with the musculoskeletal system. There are a few categories or a few topics there that you can see are related to the hip. Juvenile idiopathic arthritis is what we formerly called juvenile rheumatoid arthritis. And yeah, again, I'm not going to read all of these topics, but you can see that these are some fairly prevalent conditions and ones that you'll recall learning about in PT school and then seeing patients with these disorders in the clinic as well. And so I will tell you that out of the list that is here, we're going to address about 7 or 8 of the topics, or 7 or 8 of the conditions tonight. And this is by no means an exhaustive list, right? You're probably looking at this and you may be thinking, well, I don't see this condition there or that condition there. We could probably go on, but these are just these are some of the more prevalent ones, and the ones that came to mind, and the ones that are going to form, yeah, again, 6 or 7, 8 of these are going to be ones that we're going to talk about as we answer questions tonight. So let's do just that. Does anybody have any questions on that background information before we jump in and start actually answering some questions? Okay, well, let me get my timer set, and y'all are going to have about a minute, maybe a little bit longer than a minute, to answer each one of these questions. And what I'll do is I'll put about 30 seconds into each question. I'm going to put a poll up, and you can chime in with your responses. Please chime in when I ask you, when I tell you there's about 10 seconds left or so. Please go ahead and get your answers in. We can't tell, what each individual's response is, so it just gives us a good idea, gives me a good idea about maybe where we need to spend a little bit more time, or when we can move on to the next question. All right, so here we go. Question number 1. All right, so let me go ahead and bring this poll in. Get your answers in. Okay, take another few seconds or so to finish up. And all right, so I'm going to end the poll, and I'm going to go ahead and share the results with y'all. And you can see it looks like most people were either deciding between B and D, but let's highlight some of the key words, and that's part of the process that we want to go through as we answer a question like this. We want to identify some of the key factors, and the first thing is it talks about this being an 8-year-old boy, and that's going to be an important part of us answering this question, that information. They have chronic pain in the hip, thigh, and knee, and it says they have exaggerated trunk and pelvic movement. So if they've got some limited or painful lower extremity movements, then they're going to compensate by walking with some exaggerated trunk and pelvic motions. And so it also says that there's a limited range of motion with hip abduction and extension on the examination. Examination of the knee region is normal, even though the person was complaining about having some knee pain. That that exam, the exam of the knee joint itself, was normal. So which is the most likely diagnosis? And let me back up to something here real quickly, and y'all may be already be familiar with this, but typically, so the questions that are on the NPTE will not specify or do not specifically specify age and gender unless that becomes an important part of answering the question. And in this case, it will be. There was a time where we used to say an elderly, patient or a child or infant or adolescent or something like that. But the goal is more recently, and I think on this 2024 exam, you may see ages specified for children, for the pediatric patients, and then for the elderly as well. All right. So in this case, and let me go ahead and jump ahead to the answer. And what about 60% of y'all chose is the correct answer. So Legg-Calvé-Perthes disease is what we were going for on this one. And we typically see this in young boys, right? And you can see there's a comparison here. And again, the most popular answers were, or y'all's most popular answers were either Perthes disease or Skiffy's, slip capital femoral epiphysis. But we tend to see Perthes disease in younger children, so generally younger than in slip capital femoral epiphysis, and then and then we see it more so in males as well. As a matter of fact, I think the male to female ratio ends up being about 4-1. Insidious onset, that's going to be consistent with it as well. And the aching in the hip, thigh, and knee, well, we can see that with slip capital femoral epiphysis too. But the age and the gender in particular. Now, we see slip capital femoral epiphysis in males more so, but I think I would anticipate that a question about Skiffy's, if they were going to talk about risk factors and etiology on the exam, what they would probably really highlight, and the risk factor that is most often associated is obesity, right? We see the Skiffy's happen more in teenagers or in adolescents and in the obese. Let me go back to the question again real quickly, and let's see if there's anything else to highlight here. Just the fact that the Legg-Calvé-Perthes disease is considered to be idiopathic, childhood disorders. There's avascular necrosis that is involved. And so management is, with bracing and positioning, that becomes important in terms of trying to seat the head of the femur in the acetabulum so that as the bone remodels, that there's that it takes on as much as possible the normal shed and the normal shape of the head in relationship to the acetabulum. Other things to point out here. Let's see I just wanted to point out, and with Skiffy's slip capital femoral epiphysis, that ends up being that's a little bit of a misnomer, because that implies that the capital, the head of the femur, has slipped, when really, in actuality, what happens is that the head remains seated within the acetabulum, but there tends to be this anterior displacement of the femoral neck relative. Yeah, please remember to mute your microphones during the presentation and when you enter the room. And so any comments or questions on that one? That was, I guess we can probably go back and we can take a look at some of the other answers here as well. Hip dysplasia, we're going to tend to think of that is happening a little bit more so in females and rather than males, and in infants. Hopefully we're going to catch that early on, when the infant is weeks old, or certainly prior to 6 months. Hold on to the idea of hip dysplasia. We're We're going to see a question about that a little bit later. And then Legg-Calvé-Perthes disease is often misdiagnosed as growing pains in early stages. But children experiencing growing pains, they typically present with increased pain at night. That's a very common complaint. And they do not exhibit the loss of range of motion like what was described in this question stem. All right, if there are no questions, let's go ahead and move on to number 2. Here's the poll. Go ahead and finish up. All right, we've got a pretty close race on this one between answer A and B, and I'm going to go ahead and share the results with you just by a slim margin. The majority of the answers, or most of y'all, thought that B was the correct answer. And let's go ahead and take a look at this one. And it talks about this adolescent basketball player. They got pain in the tibial tubercle region with running and jumping. It tells us the nice thing about a question like this, and I think you'll appreciate these when you get on the exam as well, is it actually tells us what the diagnosis is. This person has Osgood-Schlatter. So what is going to be the best therapeutic intervention choice for this patient? And the correct answer on this one is what most of y'all chose, and that is B, so stretching. We want to think about, so this is Osgood-Schlatter is going to be a painful condition. It results from inflammation of the tibial tubercle at the insertion of the patellar tendon. And the disorder is typically seen in adolescents during periods of rapid growth. So in the skeletally immature, so what we see is where the apophysis is, or the epiphysis, the muscle is actually tugging on the attachment point of the tibial tuberosity or tibial tubercle, and that leads to this painful inflammatory condition. So what we want to do is we want to modify activity, maybe look at some alternate activities. It's often caused by overuse, and in this case, the basketball player, a soccer player, an athlete. So we want to ice, we want to stretch, we want, the patient may be prescribed NSAIDs, and yeah, we're going to have to limit the amount of activity. Doesn't necessarily mean that they have to be shut down altogether, but we've got to look at some relative rest and activity modification in that patient. So repetitive stresses to the inflamed tissue needs to be avoided, and that would include quadriceps strengthening exercises. Again, our goal is going to be relative rest and activity modification. Transcutaneous electrical stimulation, so TENS, is going to provide short-term symptomatic relief only, and the mobilizations of the knee may be helpful if the therapist identifies that there are joint mobility dysfunctions or restrictions, but there was nothing in the question stem that really would have led us to that is the correct answer choice. And it looks like there's only one person that selected that anyhow. So Osgood Schlatter is an example of an apophysitis. And in adolescent athletes, what are some of the locations where we might see an apophysitis? Well, we had the question about Osgood Schlatter's, but then at the other end of the patellar tendon, so it attaches to the tibial tubercle, but it also attaches to the distal pole of the patella. You may remember this kind of long and fancy name for this syndrome, but Sinding-Larsen-Johansson syndrome would be where that stress point is more at the distal pole of the patella as opposed to the tibial tuberosity. Sever's disease would be an apophysitis at the insertion of the Achilles tendon. We can also have an issue at the attachment of muscles to the ASIS. So we know that we have a couple of muscles that attach in that area and along the iliac crest as well. And then Little League elbow is an eponym, but that would be an apophysitis that occurs at the medial epicondyle of the humerus. So these would certainly be conditions that we want to keep our antenna up for in the clinic, but then in terms of potential questions on the NPTE as well. All right, let's move on to number 3. Okay, go ahead and finish up. So if any of you have taken our 2-day prep course, then you may recognize this question. And let me go ahead and share the results with you. And I see Shannon, yeah, just a minute, and I'll go ahead back to that slide after we're done with this question. But yeah, it looks like 80% of y'all chose B, and let's go ahead and highlight our keyword here. This is kind of a short question. So osteogenesis imperfecta, what we want to remember is that, so that is what we call brittle bone disease. There's a defect in the gene that produces the collagen fibers that are going to serve as the bony matrix, what really provides the structural integrity to long bones. And so we got to be really careful when managing these children and knowing that their long bones can fracture very easily. And so the correct answer on this one is what, 80% of y'all chose. So well done. Great job on that. Really, each of the other answer choices that are here could potentially set that child up for a fracture, right? The repeated pounding on their lower extremities by having the child run for 6 minutes, with using passive range of motion. When we get to the very end range of motion, and I'm trying to demonstrate this on the camera, right? We get to the end range of motion. If we apply a little bit of overpressure, then that could potentially set that child up for a fracture. And the same thing when we do manual muscle testing, we're asking the child to perform a maximal isometric contraction. and that can lead to fracture through, tugging on the tendons at the attachment points of long bones. And so, again, for those of you all that have taken our course, you probably remember seeing these pictures, but in the top left there is a deformity in the humerus that we can see just doesn't have that structural integrity. And in the bottom right, so like it says here, the tibia, which is almost non-existent, right? That it has had to be rotted. Perhaps it's been rotted because of frequent fractures. And here is the fibula, right? That little wisp or ribbon-like structure that we see in the lateral aspect of the leg. And so we want to keep in mind, that we've got that these childs, that their bones can fracture, that they are brittle, and they can fracture very easily. So things like doing passive range of motion assessment is going to be contraindicated, doing manual muscle tests as well. The correct answer is what is highlighted in green, so assessing strength through observing functional movements. And yeah, so it's all about safety, making sure whether we do an assessment or intervention, there's going to be this strong safety factor that we want to make sure that we take into consideration when working with a child with osteogenesis imperfecta. Let me go back to this last question real quickly. And I think that was a slide. Shannon, you had asked me about going back to that one. Is that what you wanted to see? Okay. Is that good? We ready to move on? Okay. All righty. Okay. So let's move on to a question. Let me get through these information slides and everything. And here's question number 4. Here's the poll. Take a few seconds to finish up. I don't know about y'all, but that baby, I always look at that baby and it's just kind of the creepy computer generated image, isn't it? It's just all right. Okay. So let me go ahead and share the answers with y'all. And it looks like most people chose number 1. Is we're looking at this child. The first thing we have to do is we have to do an assessment. And what is being exhibited here would be a right-sided torticollis, right? A right torticollis. So it's the sternocleidomastoid muscle that's going to be involved. And if it is tight, so the right sternocleidomastoid would do what? It would bring the child into right side bending and then left rotation. So those are the actions for the sternocleidomastoid. So ipsilateral side bending and contralateral rotation. And generally, as a treatment strategy, if we can work on one of those components, and I think the side bend component is probably the one that is easiest to work on, then usually what will happen is as the side bend component melts away, right, and the the tightness of the muscle melts away, if you will, then the rotational component will follow as well. And so let's go ahead and take a look. The correct answer is what most of y'all chose. So what about 60% of y'all chose? And what that looks like is shown on this slide here, right? So we can hold the child in right side lying, and with the forearm in this case, just provide a sustained stretch into left side bending. That'll stretch that right sternocleidomastoid. And again, what should happen is the rotational component should be corrected as well. Now, what addressing a torticollis can help do too is help to prevent development of plagiocephaly. Now, our question, that last question, was about a child that has right-sided torticollis. What is shown in this image on the left is a child that has left-sided torticollis. And if they spend any time in supine, right, with their head rotated to the right in this case, then with those suture lines that are not yet fused in an infant where the suture lines are not yet fused, the fontanelles are open, then what that can lead is that can apply pressure back here to the occipital bone and to the parietal bone, and that can lead to that plagiocephaly or flat skull. Now, in some instances that I mean, it can range from in terms of issues from just being a cosmetic deformity to there actually being some issues with the brain. But treating the torticollis will help to prevent another pediatric musculoskeletal disorder or condition, and that would be plagiocephaly. All right, let's move on to number 5. Here's the poll. Take about 10 seconds to finish up. All right, so let me go ahead and share the results with you. And I got a direct message in the chat box, and I just want to go ahead and answer that. So before we actually take a look at the answers to this one. So a left-sided torticollis would mean that the child's head is positioned in left side bend and right rotation. So we can see that left-sided torticollis in the picture of the child on the left, where I've got the laser pointer. But if they spend, if they spend any time or quite a bit of time in supine, like what we can see over here on the right, then what happens is the occipital bone and the posterior part of the parietal bone can be flattened and can shift because the suture lines are not closed, the fontanelles are not closed, and we still have those open suture lines as well. And so that can result in flattening, in this case, of the right posterior part of the head, so specifically the occipital bone and the parietal bone. So hopefully that answered the question. All right, let's go ahead and move on to this next one. And so again, most of y'all chose C is the correct answer here. And it says in the plan of care for a 6-year-old with Duchenne's muscular dystrophy, which intervention could hasten, that is, speed up deterioration of the patient's function? What we want to remember about Duchenne's is, and again, this, it's could it be neuromuscular or could be musculoskeletal. I think we could, as for the purposes of the exam, we could probably categorize it either way. But there's a defect in the gene that produces the protein dystrophin. Dystrophin anchors the contractile apparatus to the sarcolemma, to the muscle cell membrane. Remember, the contractile apparatus is going to be the actin, myosin, troponin, and tropomyosin. And so if we don't have that anchor and that structural integrity provided by dystrophin, well, then the muscle's not going to work, and there's disuse, there's deterioration. We want to remember with Duchenne's that this is an X-linked disorder. We see this in boys only. These boys often have pseudo-hypertrophy of the calves. Their calves look really, really big, right? Like they're really muscular and they could jump real high and that kind of thing. But really, in fact, their calves are filled with fat and connective tissue because the muscles have atrophied and deteriorated. These boys also tend to be they're typically in a wheelchair by age 12 and die sometime in their 20s or 30s. So the answer choices that are here, there are 3 things that we would want to do with a child that has Duchenne's, but there is one thing that we would want to avoid because it could speed up deterioration of the patient's function. And that is what almost 3/4 of y'all chose. So 72% of you chose the correct answer. So well done on that. Great job. And I would just add that there have been a couple of studies that suggest that eccentric strengthening in particular can be harmful for the child with Duchenne's. We would want to implement comprehensive energy conservation techniques. We can do active range of motion exercises and not be concerned about them. And why do we use night splints? To prevent things like plantar flexion contractures, because those can develop in these children. Okay, all right, last question of the evening. Here's number 6. Sorry. Here's the poll. Okay, take about 10 or 15 seconds to finish up. Go ahead and bring up some of those keywords there that we can take a look at. And here are the results. And it's so almost 50% of you chose D. So that is the D is the, or number four, answer number four is going to be the leader in the clubhouse. So hip dysplasia. So children with hip dysplasia can, the joints will dislocate or sublux very easily. As it says here, a trial of conservative treatment is going to be done to avoid surgery. So the child is wearing this hip positioning harness, which I think most of us recall are going to be, that's going to be called a Pavlik harness. And they're allowed to be out of the harness during PT sessions, but what position should be avoided when out of the harness? And the idea here is we don't want to dislocate or sublux that joint. So what position do we want to avoid so that doesn't happen? And what most of y'all chose is indeed the correct answer, right? And so typically, and we'll see a picture of them in a harness in just a second, but we want to think about what is going to seat that head of the femur deeply into the acetabulum, and it's going to be what we see with a harness is that the hips are going to be in a little bit of flexion, and they're going to be in abduction. So not adduction and internal rotation. We can almost think about, what are some of those positions we want to avoid in a patient who has recently had a total hip replacement. We don't want them to cross midline, right? And internal rotation as well is another one that may potentially do that. The flexion, the extension is going to be the concern here. Oh, just a real quick comment about this, and this is an editorial comment on my part. So the questions that you're going to see on the NPTE are all supposed to be positively stemmed. I would say that this one is a little bit of a negatively stemmed question, because what we're saying is, what should you avoid? Whereas what you'll likely see on the NPTE, if we turn this question around, we could say, what would be, what is the optimal position to, prevent dislocation or subluxation or something like that. But yeah, in this case, the child is most likely going to be wearing a Pavlik harness. The device keeps the head of the femur completely seated in the acetabulum by positioning the infant in kind of a frog leg position. So the hips are going to be positioned in flexion, abduction, and a little bit of external rotation with the knees flexed. And hip extension, adduction, and internal rotation are going to be the ones that we want to avoid. So here's a picture. Y'all can see I shared the website for this. I thought there was a nice informational page from Boston's Children's Hospital that talked about the Pavlik harness, and this is a good look at the positioning as well. It's important, for clinicians, whether it's us or nurses or whoever is working with the infant, to catch them, to catch these infants relatively early on, because this kind of bracing has been shown to be effective early on, maybe up to about 6 months of age. But in older infants, when they start walking, like if they're older than 9 months and they're beginning to walk independently, the Pavlik harness is probably not going to be the treatment of choice. But there can be an abduction or orthosis that can be used in when upright and when walking. And so yeah, just a consideration. The timing, the age of the patient is going to be an important consideration. You may get a question about that on the NPTE that says, what would be the best device to use in a 12-month-old that has hip dysplasia? Well, it wouldn't be the Pavlik harness. It would be some type of abduction orthosis. So. All right, folks. So on that one, let's see. Yeah, about 50% of you got that one correct. I would say Developmental hip dysplasia or developmental dysplasia of the hip is certainly something that you would want to make sure that you review in preparation for the NPTE. As we take a look back about these, potential conditions that could be asked on the national licensure exam that is related to pediatric musculoskeletal or orthopedic, or we could even say neuromuscular disorders. We've talked about 7 or 8 of them here, and I think, Shannon, I think that you could potentially, you may see a question that deals with head shaping helmets for plagiocephaly on the NPTE. I will have to admit, I'd have to look at the exact parameters and timing and prescription and age for all that. So maybe that can be your own homework assignment, but I think that would absolutely be fair game for questions on the licensure exam. And let's see. With that, we're coming up close to the top of the hour. Any final questions before we break for the evening? And I just wanted to remind you that this session is being recorded, especially and this applies to all of you. But as far as these online office hour topics go, next week, Dr. Scott Schaefer is going to cover a neuromuscular topic. And then the following week, Kelly McCauley, who is the chapter author for our cardiovascular and our pulmonary chapters in the review and study guide, she's going to be presenting. I want to say that it's on the cardiac cycle and arrhythmias and those kind of things, but definitely on a cardiopulmonary topic. And if I've got a question or a request to go back to question number 4 here real quickly, and we've got that flashed up there, so I'll leave that up for a minute. But otherwise, if y'all don't have any other questions, thank you for joining us tonight. And good luck to each and every one of you on the NPTE. For some of you, it's right around the corner. For others, yes, you got the exam coming up in April. And I see one final question. So Thomas Gray, how would the presentation differ between Osgood Schlatters and Sending Larson Johansson? So palpation, I think, would be the biggest thing, right? And first of all, Osgood Schlatters, they're likely going to have an enlarged tibial tuberosity, but definitely palpation at the tibial tuberosity, you'd find tenderness there in Osgood Schlatters. Sending Larson Johansson disease, you're going to find tenderness at the inferior or the distal pole of the patella. All right, y'all are welcome. I see your comments in the chat box, and thank you. And as I said, good luck to each and every one of you. And hopefully we'll see some of you back here over the next couple of weeks. Good night, everybody.